Welcome to the deep dive. Today, we're tackling something really critical in healthcare, something that affects everyone: how hospitals actually learn when things don't go as planned.
That's right. We're exploring incident reporting systems, basically, how safety issues are flagged and addressed.
And why they're just so crucial for, making healthcare safer and improving the quality of care overall.
And we got some really interesting sources to guide us. We'll be drawing on guidelines from the World Health Organization, a specific study from an Estonian hospital giving us a real-world view,
Oh, interesting.
and also some practical insights from healthcare organizations that are actually doing this day to day.
Great. So our mission really is to get a handle on the whole process, from identifying a potential safety problem right through to the changes that happen because of it.
Yeah, understanding how these systems function as like a safety net.
Exactly. Okay, let's dive in. First off, what exactly is a patient safety incident? What falls under that umbrella?
Okay, so one of our sources defines it pretty clearly. It's basically any event, could be clinical, could be
Oh,
non-clinical.
clinical too. Okay.
Yeah, anything that results in harm to a patient, or even just it could potentially lead to harm.
So the potential is key too. It's not just about actual harm done.
Precisely. Those near misses, where maybe an error almost happened but someone caught it, they're incredibly valuable for learning.
Right. You want to catch things before they cause harm.
Absolutely. And the scale of this, well, it's significant, especially in low and middle income countries. One estimate suggests around 134 million adverse events happening in hospitals each year.
Wow, 134 million. That's huge. It really drives home why understanding these systems is so important for everyone interacting with healthcare.
Definitely.
So once these incidents or near misses happen, how do you actually encourage people, the staff, to report them? It seems like that could be tricky.
It really hinges on building the right kind of culture. This is something the WHO guidelines really emphasize. The focus has got to be on learning and improvement.
Not on blame.
Exactly. Not pointing fingers.
That makes intuitive sense. Fear would just shut reporting down, wouldn't it?
Completely. Both the WHO and that Estonian study we mentioned talk about needing a just culture.
A just culture.
Yeah, it means creating an environment where staff feel safe reporting incidents, even their own errors, without fearing punishment. The focus shifts
From the individual.
to the system, asking why the error was possible in the first place. Was the process flawed? Was there confusing labeling? Things like that.
So it's about fixing the underlying problem.
Precisely. The WHO points out quite rightly that punishing staff for errors caused by, say, poorly designed systems, it just leads to underreporting,
Which means the risks remain hidden.
and opportunities for learning are lost. It's counterproductive.
It really is. That Estonian study finding about voluntary and anonymous reporting seems relevant here too.
It does. They found staff were encouraged to report whether they witnessed something, detected it later, or were even involved somehow. And that anonymity option,
Can really lower the barrier, I imagine.
it builds trust. It encourages openness when people might otherwise hesitate.
Okay, so we understand what the incident and the why, the just culture needed for reporting. How do hospitals actually build these reporting systems? What makes one effective?
Well, the WHO lays out some key elements. First, actively fostering that positive, learning-focused environment we just discussed. That's foundational.
Right. Culture first.
Then you need really clear, easy-to-use processes for staff to actually identify and record an incident. No complex hoops to jump through.
Keep it simple.
Yes. Third, you need to be thoughtful about what information you're asking for in the report. Not too much, not too little. Just the essentials.
Goldilocks principle.
Kind of, yeah.
Yeah.
And finally, and this is crucial, you need to find ways that these reports will actually be used.
So they don't just vanish into file cabinets somewhere.
Exactly. They need to feed into an improvement cycle. The WHO even has something called the Minimal Information Model for Patient Safety, or MAMPS. Yeah, think of it as a standard template. It outlines key data points, like the type of incident, location, harm level, that should ideally be collected consistently.
Standardization. That helps compare apples to apples, presumably, across different departments or even hospitals.
Precisely. It makes analyzing the data for broader patterns much easier.
What about the details within a single report? What kind of info is usually captured?
The WHO suggests a mix. Some structured information, maybe drop-downs for incident type, location, things like that.
Easy to categorize.
Right. But also, crucially, space for a free text narrative.
Ah, so the person reporting can explain in their own words what happened.
Exactly. That narrative often contains the really rich context and nuances that structured fields just can't capture.
That makes sense. Sometimes the story is key. How did this look in practice in the Estonian hospitals?
Well, that study found they had systems used across all units. And importantly, the local unit managers were responsible for reviewing the reports from their specific area.
So it wasn't just a central faceless committee.
No, the people closest to the work were involved in reviewing and then, crucially, planning improvements based on those reports.
That seems like a good model, local ownership.
It allows for more tailored and probably quicker responses. Okay,
That
so reports are coming in. There's a system. Now, the big question, how do organizations actually learn from all this data?
Right. Collection is one thing, analysis is another.
Absolutely. And it shouldn't just be one person looking at them. The recommendation is often for a dedicated team or committee.
Multidisciplinary.
Yes, ideally.
Yeah.
Doctors, nurses, pharmacists, administrators, maybe even safety experts. Bringing those different perspectives together gives a much fuller picture.
And what tools or methods do they use for analysis? I've heard of root cause analysis.
Yes, RCA is a very common one. The idea is, one source puts it, is to really dig deep. Don't just stop at what happened, but figure out how it happened and, most importantly, why.
Like peeling an onion.
Exactly. Getting to the core issues. It moves beyond blaming an individual to finding those latent system weaknesses. It's like being a detective, really.
So not just nurse X gave the wrong drug, but why was the wrong drug available? Was the packaging similar? Was the protocol unclear?
Precisely. And there's an emphasis now on a more human-centered approach to RCA.
Human-centered. How so?
It means really considering the context the staff were working in. What were the pressures? Were they fatigued? Were there communication breakdowns? Asking why did this patient fall involves looking at staffing, environment, patient condition, everything, not just they fell.
That sounds much more holistic. Are there pitfalls with RCA? Things to watch out for?
Oh, definitely. Bias is a big one.
Yeah.
We humans have tendencies that can get in the way.
Like what?
Well, there's the fundamental attribution error, our tendency to blame the person's character, they were careless, rather than the situation. The system made it easy to be careless.
Oh, okay.
And something called the severity effect, where if the outcome was really bad, we assume the cause must have been equally significant, potentially missing smaller contributing factors that built up.
Interesting. So awareness and training are needed for the analysis team too.
Absolutely critical. Understanding these potential biases helps ensure a more objective and useful analysis.
So assuming you have a good system and a well-trained team doing the analysis, what are the payoffs? What benefits do these systems bring?
There are quite a few. Identifying those root causes is key, obviously. That directly leads to opportunities for improving policies and procedures.
Makes sense.
It also helps manage clinical risk by flagging potential dangers before more incidents occur. It supports continuous quality improvement CQI because you can track trends over time.
See if certain problems keep recurring.
Exactly, and it provides fantastic material for staff training and just ongoing learning across the organization.
That continuous improvement loop again. Did the Estonian study show this in action?
It did. They analyzed almost 2,000 reports. Common themes emerged around patient behavior and accidents, for example.
And they made changes based on that.
Yes. Improvement actions often focused on direct patient care changes, staff training or reminders, fixing equipment issues, or even organizational adjustments. Medication and transfusion safety were areas that saw quite a few targeted actions.
So they used the data to focus their efforts. Okay, we've got reporting, analysis, but the end game is actual improvement, right? Preventing future harm.
That's the ultimate goal, absolutely. Yeah. The WHO stresses this. It happens through different levels of review.
Levels.
Yeah, some incidents might just need an individual review. More serious ones warrant a full, deep investigation. But you also need to step back and look at the aggregated data, all the reports together, to spot those wider trends and patterns.
Looking at the trees and the forest.
Precisely. And the analysis is the end point. It has to lead to action plans. And then, critically, implementing those plans and making sure the changes stick.
Follow through is key.
It is. And the WHO acknowledges this can be tough. Time pressures, maybe a focus on just filling out the forms rather than deep reflection. These can be barriers.
So it requires real organizational commitment, doesn't it, to make time for learning?
It really does. Transparency and independence in the analysis process help build trust. Knowing the data won't be used punitively encourages honest reporting and analysis.
And who benefits from this data?
Potentially everyone. Frontline staff, managers, regulators, researchers, even patients, and the public, depending on how it's shared. Clear policies on confidentiality and anonymity are vital here, of course.
Right. Building that trust again. Can you give a few more concrete examples of the kinds of improvement actions that come out of this? Like from the Estonian study?
Sure, things like specific staff training sessions or reminders about guidelines were common.
Okay.
Changes in patient care practices, maybe increasing observation frequency for certain patients, or mandating medication reviews.
Practical stuff.
Vary. Environmental changes, like installing grab rails to prevent falls. Actions related to equipment, reporting faulty items, ensuring repairs happen.
Excellent.
And even bigger organizational things, like looking at leadership practices or ensuring staffing levels are adequate for the workload.
So it can range from quite small adjustments to pretty significant systemic changes.
Exactly. All driven by learning from what was reported.
Okay, so let's try and wrap this up. If we boil down this deep dive, what are the main takeaways about incident reporting systems?
I think the core message is that these systems are absolutely fundamental for taking a proactive approach to patient safety. It's about shifting
Away from blame.
towards identifying and fixing those underlying system weaknesses that make errors more likely. It's systemic thinking.
And that idea of learning from every incident, big or small, near miss or actual event, seems vital.
It's the engine of continuous improvement. That ongoing cycle of reporting, analyzing, learning, and changing is what builds a truly robust safety culture.
Which ultimately leads to safer, better care for patients.
That's the goal.
It really does make you think, doesn't it? About the systems behind the scenes in our own healthcare interactions. How might that stronger focus on learning, truly learning, rather than just assigning blame? How could that change things for the better? What does transparency really look like in this context? Some food for thought there. Thanks so much for walking us through this.
My pleasure. It's a vital topic.